Morning, everyone, or just about. So myself, Shaun Allcock, Head of Health and Social Care Systems. I appreciate there is a spelling on there in health. I'll point it out before anybody else does. It does need an extra L in there. But what we're here today to talk about, along with Jack, who's our programme manager, or a programme manager, it's just about our digital journey. So just as a bit of an overview, there's a little bit about what our digital strategy is and what that consists of, and some of the things that we've already done so far, and touching on how we've been supported in doing so with the Access Group, and not just straightforward in terms of pure purchase of products. It's also about how do we integrate as well, so we'll be touching on that a little bit. And then we're talking about our DCF programme, and Jack's going to spend some time talking about that, to be fair, which just looks at some of the funding that we've applied for, received, and then how we've built a programme around that, and how we're going to deliver on that, really. So in terms of digital strategy, so we have a digital strategy. We built this out in 2021, September. It's about 193 pages in its entirety. We have easy to read versions. We've got videos. We broke it down into different versions, so 11-page easy read, 1-page sort of document, and I know it's hard to see probably at the back there, to be fair, but that's essentially the strategy on a page. It consists of 3 ambitions supporting the centre vision, and much like the sort of a plan for digital health and social care to national level, some of the themes that came out from our engagement were around digitise. So really, as you would expect, digitising pathways, redesigning, and again, we've used the word reimagine today, but that's genuinely what we do within our teams. We go in, we work with people and understand what we can do to make things easier, reducing that burden again. Connect, so that's some of the stuff that we've heard about. How do we make sure that things are accessible? How do they work? What's our infrastructure look like? How do we invest in that? And I guess I should point out some of the stats in terms of that digitised part. 70% of service leads are planning levels of redesign, just because of inefficiencies, right? So, if we've got 70% of our staff believing that there's inefficiencies and things that need to change, then it makes sense for us to build a strategy around that and deliver on that, really. Likewise, if we've got 65% of our staff telling us that they believe that IT is unreliable, then we need to do something about that. And then finally, we have inform, which is around how do we connect everything together, how do we integrate systems, and how do we present that back out to make informed decisions in terms of operational planning or delivering patient care. So the digital strategy consists of about 15 themes, and again, I was on the back table and I appreciate that this is very hard to see, but some of these themes that we've got in here are a lot of common sense. It's around how do we, so choice and empowerment, how do we make systems that are available to people and accessible to people, considering equitable access and things like that. Wellbeing and prevention, we've got in there digital inclusion. We spent a lot of time, not just in systems, but in our teams and the way our teams are made up. So we have our digital training team that invests heavily in engaging with the community, but also how do we source devices, how do we source SIM cards. We've done a lot in the community to, break that barrier and overcome some of the digital poverty that we see. We've got things like remote working and supporting that and enabling that. Service user engagement, information data and management and business intelligence, and various other things that we've got over there. Estates as well, so working with estates in terms of infrastructure again. We're a trust that's got lots of buildings. I can't remember the last count that we've got, but we're probably in the hundreds of different sites and different locations that we need to be responsible for and maintaining, really. So some of the things that we've actually achieved as a result of the digital strategy, and I'm not going to go into the great detail of every one of these, but hopefully some of these things may resonate or pique somebody's interest. Feel free to ask after this, or we've got a table at the back there that'll take some questions as well. But some of the things that we've done, and we're quite privileged that we've got a bespoke sort of team, so we can build anything from the ground up. Anywhere between 6 and 8 people within that team that can focus on building things like, we've got a referral portal, and that helps to bring a lot of organisations together. Historically, before we started this journey, people would send emails, SMS, use messaging services to do referrals, and it was just very unstructured and so much time wasted and so much inefficiency in that process. So we built our own referral portal that now I think there's about 40, somewhere between 40 and 50 organisations now using that portal. So that isn't just within the trust, that's external partners using that trust, using that system to make referrals into our services. So a great job in building that out, and we'll hear a bit more about some of the phase 2 of that, about how we're integrating with the referral API that's now available and things like that. Our e-consent platform, again, it's a key product for us that helps to do e-consent around school-aged immunisations. So we've got the custom-built Android app. It's portable, it works offline, it synchronises back. We have done integration through the assessment API back into Rio that we are testing and working on that as well. EOBS, I mean, this is an interesting one, to be fair, given what we've heard today. To be fair, we've had our EOBS platform that we built custom for the last 3 years, and some of the things that came out of today in terms of what the next product looks like for access. Some of the stuff that we've already covered in terms of it's got offline capability, it supports agency work, and we've started an integration to put that back into an assessment form via the assessment API. We are looking, it's just therapeutic that we've done that for, but we are in the realms of looking at taking something from Access Group. And I'll be honest and transparent, yesterday I was in a conversation where we decided that that wasn't going to be the route for us, but having heard some stuff today, I think we would look at that. Because of the stuff around offline capability, portability, we were getting to a point where we're going, well, actually, that might not be a suitable product. So having heard some of the stuff today, we can obviously reassess that. RPA, we do lots with the RPA, and I figured I'd mention that because we do RPA within the clinical system. Again, things like if you consider death registrations that are a daily task in terms of keeping that synchronized into your local systems, we use things like RPA that help to do that on a daily basis, meaning that our support staff that used to spend hours every single day doing that don't have to do that anymore. We do lots around data quality, so we establish data quality and then either remind people to do stuff or we actually do go and fix stuff with RPA as well where we can. Rheumatology portal, so that's about patient-facing outcome measures, and again, facilitating how we get that information and store that in a central place. We've got things like Scan to Rio so that people can use any MFD device and scan into Rio and things like that. We have Care Portal that looks at bringing a lot of information across all of our different systems together, sort of as a business continuity platform, which is key, but also it obviously does the level of bringing that care together so that there's a joined up shared view of that. And then some of the sort of implementations that are more off-the-shelf products. Patient knows best, so our approach to patient portal and a front door as such as PKB. And I'll go into some of the details. So this is sort of top level, and there's some detail to some of these as I get through it. Virtual assistants, so how do we support, cancel, rearrange of appointments and things like that with the chatbot. So we've got some of that going on. One consultation, and you'll get to hear a little bit about how we've taken the Rio video consultation module, and that's been in operation for the last couple of weeks for us, to be fair, so that's pretty much hot off the press, and, you know, if there's anybody that wants to understand some of the lessons we've learned in that, then, you know, you can have a conversation with us. We do things around hybrid mail, saving lots of money with hybrid mail. We've got Rio Mobile, Total Mobile, you know, people know that's different things. But we saw from Southern Health earlier, you know, it's a similar adoption for us and it's a similar process in which we're doing. We've got EPMA, not necessarily the Access Group module, different supplier, but nonetheless we'll see how we are reliant on Access Group to support that as well, and GP Connect, which we've seen earlier as well. So in terms of how, so what I've done is chosen a few of those things and said, well, how have we, you know, gained support from Access Group along the way? So when we look at Patient Knows Best and what we've done with Patient Knows Best, a lot of this is around the other APIs that are available. And again, we've heard today about how that's sort of the future ambition of Access Group and how we're building that out really, so that anybody can access information. Well, we've already got a set of information that's available. Again, stuff like progress notes, stuff like assessment APIs. But some of the work we've done around PKB and our mental health teams is to look at how we have certain forms like recall, about me, dialogue, aligned with PRSB standards, and how do we surface that up in PKB, but how do we capture all that information from there back into Rio as well. So we've done lots of great stuff around that. And again, there's some stats throughout these slides. So, something like 128 appointments available through that platform is quite significant as well. It's great to empower the user, the service user, in getting that information. Access to care plans, phenomenal piece of work to again empower that user. So we're really living up to the values of that strategy that say choice and empowerment, and that's what we're aiming to drive as a result of something like PKB. Virtual assistant. So we've piloted this, and this has probably been live for 12 months or so. But we see, again, great benefits of that. And when we start to look at some of those stats, and you see 37% of conversations that are happening out of hours, you can start to see that makes a real difference again, where users wouldn't be able to go anywhere, wouldn't be able to get any information. We've now empowered those users to really do that. And again, 204 admin hours estimated in terms of that saved hours per service per year. We are looking at rolling this out again. Jack will probably touch on that a little bit in terms of what we're doing in the future. Rio Mobilise. So we typically call it Total Mobile internally, but the sort of mobile offering within Rio. So we've got 672 active users of that system, but obviously what that helps to drive is some of those stats there, 37,000 visits per month that are using that device. And that's, again, it's a phenomenal amount of visits and I guess efficiency gains as a result of that. Things like reduction in mileage claims, reduction in costs, reduction in visit back to base. So we're not wasting a lot of time travelling around. There's a lot of efficiencies driven as a result of that. It's had its ups and downs, it's had its problems along the way, but we've worked together to iron out those things, and through constant feedback and collab, we've managed to iron out a lot of those problems as well along the way. So EPMA, now again, what I've tried to do is purposely make a mix of the things that I'm talking about, so it's not just completely about access products, but it's about some of the products that aren't access groups. So EPMA isn't access groups module, but actually through the APIs like progress notes, we get to synchronize information around, well, what's this person being prescribed through those as a result of that progress note. Or we use it for admissions data, so as soon as somebody's admitted within Rio, we can push that admission data back over to our systems as well. But again, some of the great stats there, 98,000 electronic prescriptions sent already. And again, this has really been rolled out in the last year as well, so some great figures there for only 12 months worth of this adoption. 52p cost drug chart avoided, per drug chart avoided, I should say. Power BI, so again, not a product as such, but without working with Access Group and getting snapshots and regular snapshots, we wouldn't be able to produce some of these dashboards. So we've got 385 Power BI dashboards, largely based around the information that's within Rio. So again, without working together, we couldn't possibly do that. We couldn't possibly deliver on our strategy of informing people. GP Connect, we've heard a lot about GP Connect, or we've heard from Southern Health earlier. We've surveyed people, and we see 75% of clinicians suggesting that they're saving 4 or more hours per week as a result of using GP Connect. 90% of clinicians strongly agree that the speed of their clinical decision making has improved. So again, a great feature that now is fully rolled out for us, and we see great usage of that. Again, about 20% of our users use that on a regular basis, and that's without much training or without much promotion really along the way. Video consultations, so this went live 24th of April, so just a couple of weeks ago to be fair, and we've already seen 3,000 video consultations starting to be planned within there. We've seen some successes, we've got lots of lessons learned, but that's less around the product and more around our operational use. So how do we ensure that we get SMSs out? How do we make sure we do letters? How do we get all that information out from the system to then give that on somewhere else? So that's why I put some minuses there, just to remind me that, you know, some of the negatives associated to the way in which we were rolling this out and looking at this is things like how do we cater for recurring events, because each instance of a video consultation is a new instance. So again, lessons learned for people that are looking at taking this. Recurring events have their own unique link, and we have to think about, well, how do we then get that out? Do we prescribe in terms of letters and sending letters out? So there's maybe things to think about there. The overall access of those links, if it works, it's fine. You know, everybody gets the link, but when it doesn't, that can cause a bit of chaos. So we've had to figure out what are the backup plans for that and how do we surface that information. One of the positives that we get asked a lot is, does it support group conversations? And yes, it does. So, you know, if anybody's thinking about this and considering this, then groups are supported within there as well. Again, these stats really are in here for people to reference afterwards, you know, grab these slides and reference these afterwards. But you can see some of the stuff in there is quite astonishing in terms of savings. When you look at virtual consultations, and I mean 4.7 million in reduced travel claims since we started this, so, you know, in the last 3 or 4 years. Virtual assistant, we've covered those sort of stats. Some of the SMS figures, you know, £1 million cost reduction in terms of saving of DNAs because we can cancel and rearrange, stuff like that. So some real impressive stats there. 8 awards, look at that. It's only because it's mentioned by other people. But we've got 8 awards so far. We have been nominated for another 8 coming up in HSJ awards as well. But we've not won them yet, so we'll see how that plans out. RPA, I'll touch on that because I've mentioned it before. But for the cost of about £400, let's say, annually, we were able to release, you know, £100,000 worth of cash. 7,000 hours worth of admin as a result of that. And I mention that because I know a lot of people are spending a lot of money on things like RPA. So we'll see what else we got. Okay, so moving on to sort of the DCF programme. Let me just check. Yeah. Moving on to the DCF programme. So one of the things that we've done recently to help shape what we're delivering in terms of digital, what we're doing digitally, is around digital capability framework. It used to be called MDF, Minimum Digital Foundations. But that sets out a criteria. We looked at that criteria and said, well, how do we stack up in terms of that? And it was a difficult sort of thing that we tried to tackle internally, because you can do conversations, you can go and speak to people and they'll tell you what they need, but then turning that into something that we can deliver on, it was a struggle for us. So what we looked at is, well, let's engage with people, let's understand what they need, but then let's understand some of the product offerings that we've got. So we then said, let's list all the offerings, let's look at the criteria, and let's do a simple matrix that then says, well, what products can help us meet which criteria. We also appreciate that it's not a simple yes or no, because you could have real strong system capability, but the adoption internally might not be there. So we decided to separate that out to say, well, we'll score the systems, and it's not just, you know, the Rio system. All of our systems will score, but we'll also score our services in terms of their adoption so that we can measure and look at that, to be fair. In terms of funding, so we were the first in the country to be granted an award in terms of our application. And that's to the tune of about £3 million that we received or in the process of receiving from NHS England as a result of this. And we've matched that funding as a trust in terms of that. So we've got £6 million that we're investing into that digital maturity and that frontline digitisation process, which enables us to work, again, with Access Group in terms of what that looks like. But also it meant that we had to understand our workforce. And again, sticking point in terms of, well, how do we cost this? What's the cost model? How do we do that? Rather than doing a finger in the air, we sort of said, well, if we list all the products and we list the people that are involved, like BAs, PMs, clinical safety officer, let's start to estimate that. And we start to build out a bit of a cost model around that. And I'll hand over to Jack, really, who's going to say, well, how have we resourced that and what does it consist of? So there you go, Jack.
Thank you very much.
What do we do this?
Right, hi everybody. So following on from what Shaun's mentioned about some of the business case processes that we went through, my role is as DCF program manager, so trying to implement the projects on the program by March 2025. So in terms of how we are resourcing this, the funding from NHS England, we've been able to use that on some extra resources within the department to help us deliver these extra projects. So we've got 16.8 full-time equivalents, majority of which are on 16-month or 18-month fixed-term contracts. So the reason behind this is because this allows us to basically deliver the extra project, but still focus on our business as usual activities, the projects we had ongoing already. So this has been really great to receive this funding and obviously have these extra people in place. And this just gives a bit of an idea of our DCF programme phases throughout the years. So this is for 23-24. You can see we've got some nice green boxes here, which shows what we've delivered last year. Such as virtual assistant pilot, which Shaun mentioned, GP Connect, Care Portal, and so on. So there's many things that we worked on in 23-24, and some of the items at the end there, like pathway builds that Shaun also alluded to, around making sure that services are actually in a position to take on the new modules and the new functionality that we're putting in place. This is the programme phases for 24-25, busy year as you can see. We've delivered the first two already, obviously with it being early in the year. We've got Sensio, which is a mental health assessment tool, and Rio video consultations, which Shaun's mentioned. And then we've got many other projects that we're looking to deliver throughout the year, such as the NTRS click-through, which is in Rio, which we're looking to put live. Further integrations with our carry consent system to get the data back into the core clinical system, and click-throughs in many areas, really. I mean, a key part of this programme is trying to get as much information from multiple disparate systems into one core clinical system. So, that's where a lot of our focus is with some of these items. And then the programme also spans into 25-26 as well. So there's some things which kind of go into the next financial year. So big pieces of work like EMIS to Rio, Diamond to Rio, so on. So trying to converge onto as little clinical systems as we can, basically move off some of our existing systems, and then some other additional modules at the bottom that we're going to be looking at as well. So busy programme of work, keeping kind of track of that as we go along, and some of these TBCs will be able to kind of allocate some names against those soon. Now that's a lot of what we are doing. This is what we're doing right now. So referral portal phase 2, Shaun touched on this. Basically what we're doing now is building additional functionality into our referral portal. So that's that bespoke development to allow electronic referrals in. This will allow integration with the clinical system. So that's going to be really beneficial. Rio video consultations, although we've got that live, it's still a big priority for us to make sure that services are actually transitioning onto the new system. We're ironing out any bugs that they've got, and just supporting them in general, really. Another one, B codes, so role-based access control, making sure that the new modules that we're rolling out, people have the right access to them where appropriate based on their role in the trust, because there's no point in rolling out these modules if people don't have the right access. Rio ICE click-through, so that's all about clicking through from Rio into neighbouring trusts' ICE system, so UH&M, to see their blood results for the patients. Again, saves logging into other systems externally and has all that information in one place. PKB phase 2, so we've had phase 1 already, which is being piloted with our community mental health teams, and this is going to be looking to roll it out to additional teams as well. And then Ulysses click-through, which is our risk and incident system, so we can click through, again, from a patient record to view those items. And in terms of what projects we're looking to start imminently, virtual assistant phase 2, so that's going to be rolling out the chatbot function that we've got on the Trust website live for 2 services at the moment across more services that will allow people to inquire about their appointment from a virtual chatbot. Then we've got EOBS. This is something that we're looking at our options, as Shaun mentioned. Obviously, as of today, the direction of this may change slightly, but this is something we're looking at picking up soon, as well as Rio Flow as well. And now, just in terms of how we're actually delivering these projects. So we essentially use a bespoke project management tool within MPFT. We use it to track all of our digital transformation projects. And a lot of what I'm going to go through on this slide will probably resonate with most of you. But each of our projects reports into a program board called the DISG. That's our Digital Information Steering Group. And that's where all the briefs, changes, exceptions, and closures are monitored for project assurance. We have a weekly CAB meeting, which we use to monitor all go-lives and system changes. Each project has their own project meetings and gateway meetings, and we also have a bi-weekly program steering group for the DCF, which is where we can kind of monitor any issues, progress, good news stories on the program. And in many cases, with a lot of the projects that we're doing, we're working closely with the Access Projects team as well, making sure that the change is coordinated on both sides and we've got resources aligned. And finally, this is a point that again, will resonate with all of you. Clinical safety, now a massive part of what we do within MPFT digital projects. So each of our DCF projects has a clinical safety officer assigned, and they run hazard workshops and obviously complete the clinical safety case ready for sign-off. Now, in terms of measuring the change, so once we have delivered it, obviously we want to go and make sure that what we've delivered has impacted in the way we wanted it to. So during project meetings and gateways, we do ensure that our coverage that we set out is actually correct. So we're going to achieve the items that we said in DCF. After project implementations, we're going to obviously do some of the assessments ourselves to see where we are hitting criteria, but ultimately we do want to get a third party in as well to look at our digital maturity, to kind of do that external assessment and see where we're up to. We now perform detailed benefits realizations with staff and service users. So we have surveys that goes out. So as we implement new modules from Access, we're sending out surveys to users trying to quantify some of the benefits data, and we can share that in the benefits reports. As an example of one at the bottom of the screen there that you can see. So we are sharing these out widely with the trust. And then we can get data from the systems as well, like some of the stats that Shaun showed before. We can get lots of figures, lots of nice things that we can put into dashboards to demonstrate what we're doing. And it's really important that we obviously promote these changes that we're doing. So we've got this funding from NHS England, we're putting all these nice things in. We want to promote the benefits, make sure the rest of our staff who maybe haven't tried it yet, they see the benefits from other services and they can make the most of that. So we are sharing these benefits realisation reports across our trust, and we also have a monthly DCF programme report as well that goes out. Oops. And then finally, embedding the change. So obviously we don't want these modules just be used temporarily and then never again. We want to make sure this is embedded as BAU from the point they're implemented. So we have a team of 10 dedicated digital skills and change specialists, also known as digital angels. You might have seen that referred to on LinkedIn and Twitter. So this team drive adoption, they monitor usage by doing floor walking and training packages. Each of our projects has a tailored videos to go with them, quick reference guides, and basically this is to ensure that staff can access training anytime, anywhere, and on any device. That's really useful for like staff that work out of hours, for example, so they can just have a look at that first before looking to get a trainer. We also offer support to our local community at libraries and general groups in the area. So our digital skills team will go and see patients to make sure they're set up on the NHS app, PKB, and other initiatives that we're pushing as a trust. This ensures that the patients have the digital skills to benefit from our enhanced maturity from the new things that we're putting in place. We also have a team of 3 Associate Chief Clinical Information Officers and 19 Clinical Safety Officers, and these people act as a conduit between digital and clinical teams, ensuring that, again, the benefits are promoted and people understand why we're doing these changes to get the systems used. And then just a final point, really. Obviously, we're enhancing the digital maturity of our clinical system, but it's really important that we don't just leave teams behind, because we can have a digitally mature system, but if teams aren't digitally mature, then we're not going to see, again, those benefits that we want. So we're assessing service maturity, planning pathway redesigns to take advantage of our increased maturity in the clinical system. And that is everything. So thank you for listening. I hope that's been useful. Has anybody got any questions?
Shaun?